العملية وطبعا كل اللجنة المنظمة للمؤتمر والحياة المنصورة دايما عودونا إن هم يقدموا مستوى علمي متميز وده مش غريب في الدكتور ينفع والدكتور على الموضوع المختلف بتاعه. الموضوع بتاعنا النهارده drug handling in hemodialysis and we'll review the principles of pharmacokinetics and discuss the impact of the therapeutic functions of pharmacokinetics, discuss the impact of extracorporeal service of pharmacokinetics, drug dosing, and then have some special concentrations. First, you have to define the words pharmacokinetics and pharmacodynamics. Pharmacokinetics defines the process of drug absorption, binding, and elimination, whereas pharmacodynamics represents the interaction of the drug with its product type and pharmacologic response to it. لو البيشنت بياخد drug orally أول حاجة هيحصل absorption and then it goes to the liver to undergo the first pass, and from there it gets distributed in the body. It goes to the systemic circulation. The systemic circulation gets binding to proteins, and only the three parts will be active on the tissue receptor and produce action, and only the three parts will be dialyzed. Then the drug goes to the systemic circulation back to the liver for metabolism and or elimination, and to the kidney for elimination. يبقى steps that the pharmacokinetics absorption, distribution, which is equal to the volume of distribution, is defined as the dose of the drug divided by the blood concentration, and it tells you how the drug is distributed in the tissue. If the volume distribution is big, this means that the blood concentration is small, and this occurs more with little parts of drugs, and the reverse is true. Then we have the protein binding and metabolism, and of course the elimination and renal handling is the one which are concerned with. ايه اللي بيحصل للpharmacokinetics زي وجود renal dysfunction؟ بالنسبة للabsorption, absorption is going to be reduced because of the presence of nausea and vomiting, gastroparesis, alkalization effect of cellular urea which changes to ammonia. This will hinder the absorption of drugs that need an acidic medium. Also, the same thing goes with the use of PPIs and H2 receptor blockers, and also the use of sustained boundaries form some insoluble complexes with some of the drugs and hinder the absorption and the presence of blood leaking. What happens with distribution? I think that the number of edema or ascites, the volume of distribution is increased. And when we have muscle wasting or volume depletion, the volume distribution is decreased. And most of our patients usually fall in one of those categories. Protein binding is reduced due to the presence of hypophosphatemia due to malnutrition and inflammation, and because of competitive inhibition of endogenous organic acids that accumulate, and because of changes in albumin structure orientation induced by uremia. So at the end of the day, we have a reduction in protein binding. For metabolism, there is slowing down the reduction of hydrolysis reactions, and for the renal handling, الألف مكتوبة غلط، بيبقى عندنا طبعا reduced in drug clearance and increase in the plasma half-life of the drug. Even those drugs which are not excreted by the kidney, their metabolites may be excreted by the kidney and get activation of the active metabolites, which may be also toxic like pyridine, producing neurotoxicity. We also have changes in pharmacodynamics like decrease in the receptor number, decrease in the receptor binding, and altered signal transduction. So by the time the patient goes to end-stage renal disease, he does not only have alteration of both pharmacokinetics and pharmacodynamics, but he is also receiving multiple drugs with increased risk of drug interaction, and he is going to be dialyzed with the possibility of clearing of the drug by dialysis. So if the drug is removed by dialysis, we have to give a supplementary dose at the completion of dialysis to compensate for the amount of the drug that was removed during dialysis. So speaking of dialysis, the drug is removed either intermittently or continuously depending on the modality you are using, and the total clearance of the drug will be dependent on the residual kidney function, because most of those patients still have residual kidney function, on the dialysis clearance as well as on the renal clearance. So this will tell you the total clearance of the drug, and it is the clearance by dialysis that we're going to be concentrating on now. Clearance by dialysis, which we call the dialyzability of drugs, is dependent on drug properties, dialysis properties, and membrane properties. So speaking of the drug properties, First, we have the molecular weight of the drug. Of course, as you all know, that in hemodialysis, speaking now about hemodialysis, the solutes move by osmosis or by diffusion from the blood compartment to the dilated compartment, and the smaller the molecular weight, the more easy they are going to diffuse, and of course it also depends on the foresight of the membrane. So if you have drugs with a molecular weight of 500 atoms, they can move more freely, whereas drugs with molecular weight of 1,500, they're not going to move easily into conventional hemodialysis membranes. Well, the second is going to be the higher hydrophilicity, and the more the drug is water soluble, the more it's going to be to diffuse easily, and also the volume distribution will be small and will be present more in the circulation and will be easily diffused. Then about protein binding, you know that only the drugs which are free, that are not protein bound, are allowed to pass through the membrane. So take a drug like garamycin, for instance. It is not protein bound, it's water soluble, and it is not, it has a small volume distribution, so it's going to be cleared 100%. Then the next is going to be factors related to the dialysis itself, including the flow rate, the volume, and the duration of dialysis. So you know as the solutes move from the blood compartment to the dilated compartment, increasing the blood flow rate will deliver more drug to the membrane, and therefore the clearance is going to be increased, and also increasing the dialysate flow rate will keep the concentration of the drug in the dialysate minimum, and this also increases the clearance by dialysis. So if the extraction is going to be the difference between the concentration of the drug going in the dialyzer to the concentration going outside the dialyzer, divided by the concentration inside the dialyzer. So if the drug is 100% removed, for instance, if the concentration going in, say, is number, say 8, for instance, and going out is 0, divided by 8 is going to be 1. So when we have extraction of 1, it means that the drug is 100% removed, and in this case, the clearance by dialysis will be dependent on the blood flow rate. There is also another formula for determination of dialysis clearance, which is equal to the clearance, the urea multiplied by 60 over the molecular weight of the drug. Then the last point is going to be the membrane properties, including the foresight, the surface area, and the geometry of the membrane. And you know that changes in the technology for the dialysis have led to the evolution of the high-class membranes with high permeability, and they produce more clearance of the drugs. Of course, included in that the polysulfones and polyacrylonitrile, and of course we have also the charge of the membrane can make a difference also, because sometimes you get this drug membrane charge interaction that may result in absorption of the drug of the membrane. All these also has an effect. Now we go to the continuous therapies, and of course you can have dialysis or hemofiltration, and this is generally reserved to the critically ill patients. So any error in dosing will produce will end in a bad result. And unfortunately, many guidelines are extrapolated from experiences with the chronic hemodialysis or from theoretical considerations which are based on the principles of pharmacokinetics of the drugs or the modality of the CRRT that is used. The impact of volume distribution may be relatively smaller here because there is a continuous rate equilibrium between the different body compartments. Well, in an ICU setting, you usually have an AKI patient, and if you're using hemodialysis, then you can calculate the clearance of dialysis by dividing the dialysate concentration by the plasma concentration, and you multiply by the dialysate flow rate. Well, this dialysate concentration for the plasma concentration is called the dialysate saturation, which is a mathematical measure of the diffusibility across the membrane. So in this case, the clearance by dialysis will depend on the dialysate concentration and the dialysate flow rate. If you compare that to hemofiltration, for instance, which you know is more dependent on convection and the solvent drag. And in this case, the molecular weight is much less important because using high-class membranes, which allow the passage of up to 5,000 atoms molecules, molecular weight flow rate, the molecular weight for the drug becomes less important. And a very useful clue to the likelihood of a drug to cross the membrane is what is called the Sealing coefficient, which is equal to the concentration of the ultrafiltrate divided by the plasma concentration. And this is very much like the diluted saturation, which is the diluted concentration divided also by the plasma concentration. If this CV coefficient approach is flat, this means the drug is going to be more filterable. So this is an example of some of the drugs. If you look here, for instance, you will find the amikacin, ampicillin, giprazidine, and metronidazole. They have a CV coefficient approaching 1, and they are well dilatable, whereas if you look at the geptriaxone, for instance, and the phenide points, they are not. Well, for hemofiltration, it also depends on whether it is a post-dilution mode or a pre-dilution mode, because in the post-dilution mode, the saturation is 100%, and in this case, the formula goes like we mentioned. Clearance of the hemofilter is going to be equal to the ultrafiltration flow rate multiplied by the CV coefficient. Whereas if it is in the pre-dilution mode, the saturation is going to be reduced because of the passage of the replacement fluid with the blood in the hemofilter, and this will have to be corrected by using this formula, the second formula, which takes into consideration as well the blood flow rate and the replacement fluid flow rate. Whereas in the case of hemodialysis, the clearance would depend more on the molecular weight. Now, why are we saying all this, and why are we considering all this? This is efficiency. The first line is efficiency, and the second is toxicity, and the window in between is the therapeutic window. You can have a wide therapeutic window, and you can have a narrow therapeutic window. So the goal of therapy is to retain efficacy while avoiding toxicity. So to start to speak about drug dosing, we need to know some of the meanings here, like bioavailability determines the amount of drug reaching the systemic circulation, and therefore the amount of the site of action. The volume of distribution will determine the size of the loading dose that we're going to give. Clearance determines the maintenance dose, and the half-life determines the amount of time needed to reach a steady state serum concentrations or eliminate the drug, which is about 4 times the pH. So if you want to prescribe for a patient with renal dysfunction, you have first to ascertain the level of renal function, and then establish integrity of liver metabolism, and then establish the loading dose and then the maintenance dose, and check for drug interactions, and decide on blood level monitoring and installations of dialysis. You have to make 4 losses that occur during dialysis by giving supplementary doses post-dialysis in case of intermittent hemodialysis, or by giving augmentation for the maintenance doses if the patient is on continuous dialysis. To estimate the GFR, you can use many equations like the CRRT, the CRRT equations, or you have other equations like the ESG formula, and you have equations utilizing the biomarkers of the disease. Well, after you decide on the GFR of the patient, you start with the loading dose, which is equal to the concentration of the blood multiplied by the volume of distribution. It has nothing to do with the clearance, and it need not be altered with the renal impairment. Loading dose is required if the drug has a long half-life, if there is a need to rapidly achieve the desired steady-state concentration, and if the volume distribution is significantly increased. Then you have the maintenance dose, which is equal to the concentration of the blood or drug in the blood multiplied by the clearance, and in this case, change in clearance will require a change in the dose of the maintenance dose. If the patient is in continuous infusion, we can do that by modifying the rate of infusion. If the patient is receiving the drug intermittently, we can vary the dose or vary the frequency or have a combination of both. So if you vary the interval, you will keep the dose constant. If you vary the dose, you can keep the interval constant, or you can use a combination of those. And this is to decide on the new dosing interval. You can do that by dividing the normal creatinine clearance by the patient's creatinine clearance, and you divide by the normal interval. You can even have another formula, the rule of thumb formula. You divide the patient's creatinine by the normal creatinine, which is 1, and you multiply by the normal interval. So if the patient's creatinine is 2, for instance, and it's going to be divided by 8, if the interval is 8, you know that it's the new dosing interval. To get the new dose, you divide the patient's creatinine clearance by the normal clearance, and you multiply by the normal dose. Now these are just examples. For the new dosing interval, 100 is the normal clearance divided by the patient's clearance, and 8 hours will give you the new dosing interval. And for the dose, you divide the patient's clearance by the normal clearance by the dose of the drug, gives you the new dose, 200 milligrams. The combination methods, for instance, if you have a patient taking 2,400 milligrams in a 600 milligrams 6-hourly dose, and if the patient with renal impairment, you need to reduce the dose to 1,200 milligrams, you can do that by giving 300 milligrams 6-hourly to give fixed the interval, or by giving him 600 milligrams 12-hourly to give fixed the dose, or you can combine both like 400 milligrams 8-hourly. Well, what to choose to do actually will depend on the individual patient and on the drug, on the settings that you have. It's usually reasonable to start with increasing the dosing interval until you reach 24 hours and you start to reduce the dose. If you decrease the dose and maintain the interval, you ensure a constant drug level but at the expense of increased possibility of drug toxicity, whereas if you prolong the dosing interval, you ensure no drug toxicity but at the expense of a possibility of subtherapeutic level. So you will have to decide, and you have to be individualized, whether you start low and go slow versus going fast and starting high, and depending on the setting, whether the patient is in the ICU or otherwise. Now that in a patient who is on dialysis, you start to measure the drug, the amount of drug which is required to boost the present level to the desired level is going to be equal to the target level minus the observed level and multiplied by the volume distribution multiplied by weight. Then you can tell how much of the drug is needed to augment the dose which is already there. There are other ways to do that, like by finding out the total drug removed, which is equal to the ultrafiltration concentration multiplied by ultrafiltration rate multiplied by the time of the procedure. And if you don't know the ultrafiltration concentration, you can get it from the plasma concentration, which is, and if you don't know the plasma concentration, you can get it from the dosing rate divided by the clearance, etc. Of course, you are not expected to do all that. All what you have to do is to look up some tables, and it will tell you, this is for antibiotic tables, it will tell you what to do with the drugs creating clearances and dialysis. This all goes for antibiotics. And for antihypertensive medications, I just want to draw your attention that the calcium channel blockers and alpha blockers need no dose modification dialysis. The beta blockers, the metoprolol and propranolol will need additional dose for dialysis. ACE inhibitors, there's almost, and most of them, 50% dose reduction, and some of them will need additional doses for dialysis. RBs, not removed with no dialysis, and have no after reduced dose until 250 milligrams for dialysis. Well, in conclusion, then, we can say that the third kidney function alters drug pharmacokinetics, and clearance by hemodialysis depends on factors affecting the drug bioavailability, which are related to the drug, to the dialysis, and the membrane processes. Dose modification is crucial to produce the desired effect while avoiding drug toxicity. Extracorporeal drug clearance can be calculated based on dialysis flow rate and margin, and with this we have to consult the available literature on drug removal. Administration of loading dose only depends on the target plasma level and volume of distribution, and does not require adaptation for extracorporeal removal. Adaptation of the maintenance dose to reduce renal function should be carried out, and for drugs with a precious or dilated clearance, supplementary dose is given post-systemic dialysis or augmentation of maintenance dose in continuous hemodialysis. Supplementary doses derived from studies of low flux membrane should be apparently increased by 50% with high flux membranes, and measurement of the serum concentration should be done, especially with drugs with a narrow therapeutic window. Now, before I end, I'd like to make an announcement on the presence of a transplantation course that's going to be held at Qatar University on the occasion of the Golden Jubilee, where 50 years have passed since first initiation of the nephrology unit in Qatar. It's going to be on the 16th and 17th of October, and it's going to be followed by a conference on the 18th of October. And for those of you who are interested, the website is at the bottom of the page. It's www.nephrologycouncil2012.blogspot.com. And thank you.
Very nice presentation.
النفرولوجي سيشن ديت يعني لقينا بس بقيتنا في التفكير على الفارماكولوجي واهميته الدراج. لان في رساله المفروض احنا ما نكتبش ايه ده وايا كان لما نعرف السايد افكتس بتاعته ايه، يعني ممكن نكتب شويه ادويه نبقى عارفينهم احسن من كل الاصناف بتاعنا جوه في الاخر بنكتبه غلط. فلقيت النفروساب نزلت عدد السنه اللي فاتت تقريبا في اول السنه على رينال فارماكولوجي او فارماكو نفرولوجي. فقصه مهمه جدا وازاي نتعامل مع الدراجز، وفي ادفانس عنيفه جدا. يعني الدكتوره ذكرت ديجوكسين انتوكسيكيشن، في ادفانس في الاكسترا كوربورال سيرم دلوقتي بيستخدموا نانو ماجنتس، يعني يجيبوا انتي بوديز لها وابلاي ماجنتيك خارج فبيعكس اكستراكشن اوف ديجوكسين لدرجه انه صاروا خلال نص ساعه ففي ادفانس جدا في موضوع الدراسه ده. انا كنت منتظر اسئله كتير بس ما اعرفش الناس فصلوا ولا ايه. يا اما المحاضره مقبوله جدا يا اما ما اعرفش. محاضره جميله وممتعه للغايه. اي اسئله يا جماعه؟
Thank you.
طبعا قدم الدكتور احمد الرياض الاستاذ بتاعنا الى جامعه اسكندريه، وهو وعدني ان هو هيمشي بديفرنت ابروش، يبقى فيه انتراكشنز وصحصحه من الاول كده. هنشوف هيقف في بعض ولا بره.